So I started my series on clinical drugs earlier on, and I did one on artesunate, and it actually got some good response and some good traction on the channel. So I thought I would continue that series because a lot of you guys found it quite helpful, especially with discussing doses of drugs, which is something that is not really emphasized when you're in medical school, and you only get to actually get exposed to this when you're on the wards. And it becomes a bit of a challenge not knowing how much to give, how to increase, how to give, which formula to give, how often to give. So I thought I'd put this series of videos together, and this week we're going to be looking at the cardio section. So we'll be looking at drugs that are very important, cardiac drugs, and we'll start with the diuretics, predominantly with the one that you're going to be seeing most commonly on the wards, furosemide, or more commonly termed as Lasix or Lasix, whatever you want to pronounce it as. So grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at furosemide. If you haven't yet subscribed to the channel, what are you waiting for? Hit the subscribe button, hit the bell notification icon so you can never be missing on such amazing content every time I post. Here's a bit of some humor for those that really enjoy dark humor. I know there are some people that are very serious on this particular channel, but here's some dark humor. Of course, this is just helping you remember that whenever there's some edema, it's time to diurese. So keep this picture in mind. And this one always just cracks me up when your heart failure patient actually stops taking their diuretics. This one always just cracks me up. Right, so let's talk a little bit about Lasix. Let's talk about furosemide. I will be dealing with Lasix because that's the one that's most commonly in our setup here. There's another type of furosemide that you can actually give subcutaneously. It's not Lasix, it's another brand name, but I'll talk about it briefly. I think there was one slide that I added to that. Remember, this is going to be our prototype in terms of diuretics. It's going to have a much greater diuretic effect compared to the thiazide diuretics. We'll cover thiazides in another video. And it's quite important to remember that it is a sulfonamide derivative. This is very important. Any drug that has some sulfur component in it means that potential for hypersensitivity is quite high, potential for allergic reactions is quite high, and ideally this is a drug that's going to be quite bound to plasma proteins, so it will have a high binding capacity to plasma proteins. Then it has a rapid onset of action, especially if you're giving it IV. And remember that the IV formulation is way much potent, over 2 times more potent than the oral formulation. So for those that are coming in acutely decompensated, those that you need rapid actions to work, you're going to be giving your IV formulation. Now let's take a step back and actually look at the mechanism of action, because remember that this is working inside the renal tubules. It's going to be preventing the absorption of many ions. It's a very potent thing, and you understand why. So it's going to be preventing the absorption of sodium, the absorption of chloride, magnesium, calcium, and the absorption of water. Let me explain how this is happening. Remember that there is blood that is coming in, being filtered out in the glomerulus, and then eventually these electrolytes are filtered out into the renal tubular lumen. So this membrane that is found adjacent to the lumen is known as the apical membrane. This membrane here that is on the sides is known as the lateral membrane. Then, of course, this membrane at the base here is known as the basal membrane. This membrane here is known as the basolateral membrane. One thing you must always remember in terms of these mechanisms of actions, especially with diuretics, is that at the basolateral aspect, you have a high concentration of sodium, potassium, ATPase pumps. These are normally going to be working to push out 3 sodium ions to take in 1 potassium ion at the exchange, 2 potassium ions at the exchange of 1 ATP molecule. So they take out 3 sodium ions, they take in 2 potassium ions, and they're using up 1 ATP molecule. That's the natural stoichiometry of this channel. So remember, you're going to be having this filtration that's happening. You have water that's in the lumen. You have the sodium. You have other electrolytes that are there. Now, there is an important channel that is known as the sodium-hydrogen exchanger that is present on these cells. And remember that this sodium-hydrogen exchanger, which is found on these loop cells is going to be taking in sodium, absorbing sodium in, and excreting hydrogen. So it's going to be excreting hydrogen, making this lumen a bit more positive. Now remember that this sodium is entering into the cell. And there's another big channel that's known as the sodium 2-chloride and sodium potassium 2-chloride co-transporter. It's a very big channel because it's going to be taking in 1 sodium ion, it's going to be taking in 2 potassium ions, and it's going to be taking, rather 2 chloride ions, and it's going to be taking 1 potassium ion. So these cells actually become rich in potassium, because remember that potassium can actually enter into this cell through this channel. Potassium is going to be entering through the potassium ATPase or the sodium ATPase channel, and these cells are going to accumulate a lot of potassium. Then some of this potassium can be pumped back out into the lumen. It can also be absorbed into the bloodstream. Then the chloride that is absorbed is also going to be absorbed into the bloodstream. Now, because you're pumping out hydrogen ions, which are positive, and potassium ions, which are also positive, you're going to make the lumen of this loop of Henle, you're going to make it more positive. Now, once it begins to become more positive, remember from your laws of attraction, your like charges are going to repel. And you have these other big ions like magnesium and calcium, which don't necessarily have channels that are present, as you can see on this diagram. So these are repelled and to some extent are forced in between these cells, and that's how they're absorbed into the bloodstream. We call this as the paracellular route of absorption. This absorption of the sodium and this chloride and the potassium, this is what is known as transcellular type of absorption. But then if they squeeze in between the cells, this is known as paracellular type of absorption. So there's some paracellular diffusion that is going to happen. Now, let's say we give this person a loop diuretic with our prototype being furosemide. There are others which are known as ethacrenic acid, which can cause some ototoxicity, bumetanide, which is a bit more potent than furosemide. But remember, you shouldn't combine these drugs, especially furosemide and ethacrenic acid. Do not combine them. So when you give these loop diuretics, they're going to be coming and they're going to sit on this channel. So they'll block the absorption of sodium. They will block this absorption of these 2 chloride ions. They'll block the absorption of potassium. Now, if this is not happening, this potassium is remaining in the lumen, the sodium is remaining in the lumen. This sodium again is going to remain in the lumen. So sodium will not be absorbed, chloride will not be absorbed. And as long as sodium is not reabsorbed, this sodium potassium ATPase pump will not going to work effectively. So it means that this cell here will still maintain the loss of the sodium ions, and of course the potassium ion concentration is also going to change. Now, because now you're not secreting these positive ions, these hydrogen ions, you're not secreting these potassium ions back into the lumen cannot become electropositive. So again, these electrolytes like magnesium and calcium are going to be left in the lumen. So such that now you're going to be having a lot of these electrolytes that are trapped in the lumen, increasing the osmolarity, drawing more water into the lumen, and then you're going to lose this water through diuresis. Now, because you're losing a large amount of water, there is a potential of these type of drugs causing hypotension, so we tend to avoid them in patients that have low BPs. They tend to cause a lot of electrolyte imbalances. So they're going to cause hyponatremia, they're going to cause hypokalemia, because remember they're potassium wasting diuretics. They'll cause hypomagnesemia, they'll cause hypocalcemia, and they'll cause hypochloremia. So they tend to deplete some of these electrolytes. Some important interactions to remember. Remember, if you're combining aminoglycosides with furosemide, aminoglycosides, especially gentamicin and streptomycin, you can worsen the ototoxicity. Same thing with combining ethacrenic acid with the furosemide. Then lithium, lithium clearance is interfered with by loop diuretics, so give those with caution. Then, of course, digoxin, its effects could be potentiated by giving digoxin together with diuretics. Because remember, when you're giving your diuretics, you're going to get rid of that potassium. And once you get rid of that potassium, you have this hypokalemia in this particular patient. And remember, the effects of digoxin are going to be made much more evident. We'll cover digoxin in another particular video when we discuss the mechanism of action and how this will make a bit more sense. So please stay tuned. If you haven't subscribed, what are you waiting for? Hit the subscribe button. Comment in the section below if you want more such of these videos. A bit about the pharmacology. Remember, we can administer this furosemide orally, sublingually, which is not a common thing. I'm sure some of you will be hearing it for the first time in this video. Intramuscular, you can also give it intravenous. So it's the quickest route to get an action is IV. About 5 minutes and you're already getting an action. Intramuscular takes about 30 minutes, then oral and sublingual can take about 30 to 60 minutes. So it means that if your patient comes in acutely decompensated, for example, they're in heart failure, you want to relieve them, they have pulmonary edema, you want to give IV formulation as opposed to oral. Moreover, the oral formulation will not be absorbed so well from the gut because of the edema, the redistribution of the blood. The peak effect for those that are given IV is less than 15 minutes, and then for oral or sublingual, 1 to 2 hours. So it means if you're given IV, you should expect some sort of effect after 1 hour. Come and check on this patient after 1 hour, you should have some significant effect in this particular patient. Then the duration in IV is about 2 hours, and then orally 6 to 8 hours. And like I already told you, it's highly protein bound, about 91 to 99%. So it means that in patients that have hepatic damage, hepatic failure, those that have liver cirrhosis, it means that not a lot of this drug actually will be carried to carry out its effects. Its volume of distribution is about 0.2 liters per kg. 10% of it is metabolized in the liver. And the metabolite is glucuronide. There's a much larger compound or larger chemical name to this that you can actually look up. The half-life depends on whether someone has normal function. It's about 30 to 120 minutes. Then for those that have end-stage kidney disease, it can last in the body for about 9 hours for it to reach the half-life. And most of it is going to be excreted in the urine. If you're giving it IV, 80% of it is excreted in the urine. If you're giving it orally, 50% of it is excreted in the urine. And in an event where you actually give an overdose of a patient and you give them too much, the diuretics, you cannot dialyze it out of the bloodstream. Because remember, it's highly protein bound. So it's very difficult for you to actually dialyze it. So it means if the BPs begin to drop, you give them some inotropic support. You stop the infusion. If you're on any infusion, you stop the drugs, the oral if they're on any drugs and they become hypotensive. If they have these electrolyte imbalances, you replace those aggressively. Its renal clearance is about 2 mils per kg per minute. Now, the formulations can come either as tablets, oral solution for injection, and even a solution, or rather subcutaneous type of solution, which I haven't added here. So the tablets come in strengths of 20 milligrams, 40, 80, and 500, while the oral solution may sometimes contain some alcohol in it. So it's about 1 ml will give you 4 milligrams of furosemide. 1 ml can sometimes give you 8. 1 ml can sometimes give you 10. So there are different formulations that are there. Make sure you read and see what's there. In terms of the solution, most of them are 1 ml for every 10 milligrams. There are some which are 25 mils, meaning you have a total of 250 milligrams. There are some which are 4 mils, which have 40 milligrams, 5 mils, 50 milligrams, 2 mils, 20 milligrams. Make sure you read on the packaging to see what formulation you have. Because if you have one that is 2 mils and it's 10 milligrams per mil, so it means if you get that entire 2 mils, what you're going to be giving the patient is 20 milligrams of furosemide as an IV injection. Some indications include edema that may be associated with congestive heart failure. I've done a nice video on heart failure. You should check it out in the playlist. Liver cirrhosis, you have also renal disease, including your nephrotic syndromes. Can be used for edema, both systemic and pulmonary, for those that have raised intracranial pressure, for those with resistant hypertension. We use it for in cases of these other indications are not so common, like degradation of pancreatic enzyme supplements. I'm sure you have never used it for that. Long-term treatment of esophagitis, bronchopulmonary dysplasia is an alternative drug of choice, hemolytic uremic syndrome, in hypercalcemia, in hypermagnesemia, and hyperkalemia, though this is part of the advanced cardiac life support. Now, what are some of the doses you should keep in mind? If it's edema, you can give either oral, IV, or IM, depending on the severity. If you're giving it oral, you can start off by giving 20 to 80 milligrams once a day, and you may increase by 20 to 40 milligrams every 6 to 8 hours, but do not exceed a total of 600 milligrams per day. And 600 milligrams is rather a huge stretch. By this time, you should have considered adding some other drugs. Remember that in terms of furosemide, it may not work, especially for those patients that have a very low GFR. But for those that have a GFR that is even sometimes around 20, you may consider actually adding metolazone to the drug chart, which has a much better action even at lower GFRs. Then alternatively, another regimen that you can actually use, you can give 20 to 40 milligrams IV or IM once. Remember, the caveat here is that if you're giving IM, never exceed a single dose of 50 milligrams. And all the doses that are above 50 milligrams must be given as IV. So you're going to be giving 20 to 40 milligrams once, and then afterwards you increase every 2 hours by 20 milligrams. The individual dose that you give must never exceed 200 milligrams per dose. Then for those that have heart failure, the doses may be even larger, so you can actually even reach maximums of 1.5 grams per day. Then the subcutaneous formulation, Furosemide, is the only drug that you should think about, Furosemide. And this, you do not give the Lasix as subcutaneous. We don't. But Furosemide, which is another type of drug, we can actually, it's a furosemide, but it comes as a formulation that allows you to give it as subcutaneously. You can give for those patients that have congestive heart failure, for those that have CKD, including nephrotic syndrome. But again, one caveat to this is that you're not going to be using it for chronic use. If they need this diuretic for a longer time, you want to switch them to oral, you want to switch them to IV. You do not want to keep them on the subcutaneous infusion. So you get an on-body infuser with a pre-filled cartridge, which you can pre-program. Then you can program it to deliver 30 milligrams subcutaneously over the first hour, followed by 12.5 milligrams per hour for the subsequent 4 hours. So you're going to give a total of 80 milligrams subcutaneously over 5 hours. Then for the other indications, you can have resistant hypertension. You can give 20 to 80 milligrams orally in divided doses every 12 hours. For example, you can give 20 milligrams BD, 40 milligrams BD in 12 divided hours. Then for those that have pulmonary edema, hypertensive crisis, increased intracranial pressure, you want to give this IV, so 0.5 to 1 milligram per kg or 40 milligrams IV over 1 to 2 minutes. Then you may actually increase to about 80 milligrams if there is no adequate response within an hour. Like I said, within an hour, you should note some change. You shouldn't exceed 160 to 200 milligrams per dose. For those that have hyperkalemia, 40 to 80 milligrams IV, with hypermagnesemia, 20 to 40 milligrams IV every 3 hours whenever necessary. In terms of dose modifications, those that have renal failure may need a bit higher doses, but remember, don't give this in patients that are anuric, don't give it in patients that are oliguric. But you may actually even reach about 1 to 3 grams per day, but this should be given by a specialist, not you who's probably just getting used to prescribing these drugs. In terms of hepatic impairment, you should monitor the liver enzymes and liver function tests, especially when you're giving higher doses. Now, what's the direction and how do we administer it? If you're giving it as IV, remember the administration rate should not exceed 4 milligrams per minute. And however, your single doses up to 80 milligrams can be administered more rapidly. If you're giving an infusion, you must infuse it in normal saline, and the pH must be above 5.5. Glucose-containing solutions are not so suitable to give Lasix, so you want to give it in normal saline. Contraindications include patients that are anuric, which I've already talked about, those with hepatic coma, those with cell phone allergies, those that have hypersensitivity to the drugs, and this should already make sense. You want to give it with caution or try and avoid in patients with hepatorenal syndrome, for those that have hypoproteinemia, because it may actually reduce the diuretic effect. Remember that this drug is highly protein bound, and it may increase the risk of side effects. In terms of pregnancy, we want to avoid it generally, even in gestational hypertension, because it has a risk of maternal hypovolemia, which may be associated with giving diuretics. In terms of breastfeeding, too small of an amount to be harmful, but it may inhibit lactation. So again, we may want to avoid it in patients that are lactating. It may cause some electrolyte imbalances that I talked about: hypomagnesemia, hypokalemia, hypochloremic alkalosis, and even hyponatremia. We will cover these electrolyte imbalances in other videos. I think I've already done some videos on hypokalemia and hyperkalemia, but I'm yet to do some on sodium and magnesium as well as chloride abnormalities. Adverse effects, those that are general, you may have a granulocytosis, apart from those electrolyte imbalances that are on the previous page, plastic anemia, auditory disorders, especially for those that have rapid IV administration, for those that you co-administer with ethacrynic acid, and even those that are combined with those, the aminoglycosides like streptomycin, like gentamicin, and in those that have renal impairment. It may precipitate diabetes mellitus, eosinophilia, fever, gout, hemolytic anemia, malaise, mucosal reactions, tubulointerstitial nephritis, acute pancreatitis, shock, skin eruptions, tetany, and vasculitis. Then there are some specific effects that you must keep in mind that are very important, especially for board exams. So with oral use of furosemide, it may result in acute kidney injury. So you may also have hepatic disorders, metabolic acidosis, psychiatric disorders, urinary disorders. In cases of IM or IV, you have acute urinary retention as well as cholestasis. So just to leave you a bit, this is just a bit of some humor. There's always this big beef between nephrologists and cardiologists in terms of use of diuretics, because you know that they are quite cardinal in patients that are in heart failure, for example, but then also nephrologists want to also regulate the dose of the diuretics that you're giving. So here's some humor to actually leave on your mind. Thank you for spending your time to watch this amazing video. If you did enjoy it, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.